10 COPD papers. So the first one is NOTT and LOTT and MRC. So oxygen when it saves lives and when it doesn't. So basically only in severe resting hypoxemia. That would be if your saturation is less than 88% or PO2 at rest is 55 or less. That's the NOTT. That's 203 patients back in 1980 and the MRC in 1981. Severe resting hypoxemia, continuous oxygen, not 12 hours, not 15 hours, but greater than 18 hours a day, showed a mortality decrease of 50% at 24 months. The MRC 5-year mortality was 19% versus 41%. So we're talking about greater than 15 hours per day in the MRC versus no oxygen. That confirmed the NOTT. And then you had the LOTT. So the LOTT trial was in New England Journal of Medicine 2016, which is looking at SATs of 89 to 93%, moderate COPD and exertional desaturation, and basically did not show benefit in mortality, hospitalization, quality of life. So essentially, the mechanism is that oxygen reduces secondary pulmonary hypertension, polycythemia, both improve survival. That is in the group of the resting hypoxemia. So the long-term oxygen therapy prescribing rule is that it's PO2 less than 55, SpO2 88% or less at rest, or the PO2 of 56 to 59 with core pulmonary polycythemia. The dose is greater than 15 hours a day per the NOTT/MRC. Remember, the NOTT was really greater than 18 hours per day. LOTT is do not prescribe oxygen outside these criteria. Moderate or exertional desaturation does not benefit. So again, long-term oxygen therapy only in severe resting hypoxemia and greater than 15 hours per day. So what about smoking cessation? Antonison, 1994, JAMA. This is the famous lung health study, early COPD. We're looking at FEV1 55 to 90%, smokers 58, 87 patients. So sustained quitters, you would lose about normal 30 cc's per year. And then the non-quitters would lose 62 cc's per year, otherwise known as the Fletcher-Peto curve. You could look that up, but basically FEV1 decline rate is 50% if you sustain quitting. All-cause mortality is 0.70, the hazard ratio for someone who doesn't quit versus quitters. And the sustained quit rate, if you used behavioral therapy plus nicotine gum, was 4 times higher than in the group that used behavioral and nicotine versus placebo. So no bronchodilator, ICS, or biologic changes the FEV1 decline trajectory. Smoking cessation is the only disease-modifying intervention in COPD. So it's basically it decreases the FEV1 decline 50% in quitters, and the 11-year mortality benefit is confirmed. So basically, that is the best prescription that you can give a smoking COPDer. The UPLIFT trial in Tashkent, New England Journal of Medicine, 2008, is tiotropium. Fewer COPD exacerbations, less than 14%. This is moderate to severe COPD, FEV1 less than 70%, about 6,000 patient 4-year study. Increased FEV1 above placebo throughout, 87 to 103 cc's. The St. George Respiratory Questionnaire also improved. Wasn't a great mortality benefit. It wasn't a statistically significant p-value. It did not modify the annual FEV1 decline rate like we saw in stopping smoking cessation. But the symptoms and exacerbation were controlled, not disease modification. Respimat inhaler was advanced in 2013, showing exacerbation reduction. So it increased your FEV1, decreased exacerbation, decreased hospitalizations, did not show any clear mortality benefit. This is where LAMA became foundational treatment for COPD. The TORCH trial is now ICS and LABA, and that's New England Journal of Medicine of 2007. The salmeterol fluticasone 3-year mortality was 12.6% versus placebo, which is 15.2%. It just missed the cutoff for statistical significance, but it did decrease the rate of exacerbations by 25%. The key finding here was that pneumonia was higher in the steroid group, the salmeterol fluticasone group combination, versus placebo had a 19.6% pneumonia versus 12.3% in the placebo. So ICS monotherapy was more pneumonia without a mortality benefit. ICS must always be paired with LABA. Use blood eosinophils to guide the ICS. Eosinophils greater than 300 is the strongest benefit. So ICS LABA decreased exacerbations, maybe a mortality benefit, but critically it did increase the pneumonia risk by 7%. So we never used the ICS alone in COPD because then you don't even get that possible mortality benefit, and you're just giving yourself more pneumonia. That's the teaching there. So we don't use monotherapy inhaled steroids. Then comes the impact in ETHOS. So now we're talking about triple therapy impact, New England Journal of Medicine 2018. We're looking at 10,355 patients, FEV1 less than 50%. Triple therapy reduces exacerbations and mortality. So there you have a 0.9 exacerbation per year versus 1.21, but also had a 28% improved mortality compared with LABA. It's the first COPD drug to show mortality benefit versus dual bronchodilation. That is the impact trial, the ETHOS trial in 2020. Mortality was the strongest mortality signal in COPD pharmacotherapy. Hazard ratio was 50%. 50%. And the strongest ICS benefit was where you have greater than 300. Greater than 150 is where the benefit was started. And less than 100, there was no benefit and more pneumonia risk. There was definitely an increased risk of pneumonia, 4% absolute increase with any therapy that had the ICS. And so basically, we had a FLAME trial, which is a confirmation that LAMA-LABA was superior to ICS-LABA in the low eosinophil patients. So triple therapy wins for high-risk COPD. The ETHOS trial in New England Journal of Medicine showed the best compelling COPD mortality number of 50%. Remember, the IMPACT trial had about 38% improvement or 28% improvement in mortality, and the eosinophil greater than 300 is the strongest ICS benefit. The LAMA-LABA beats ICS-LABA in low eosinophil state. That would be the FLAME trial. So you should be familiar with the IMPACT, the ETHOS for triple therapy, and then dual therapy still better in the FLAME trial. The next study is paper number 6 is ensifentrine, Enhance 1 and Enhance 2, 2023 studies. Basically moderate to severe COPD. It's a new drug, phosphodiesterase 3 inhibition and 4 inhibition. So basically the phosphodiesterase 3 inhibition causes bronchodilation, 4 inhibition causes anti-inflammatory. It's different than everything else. FEV1 is improved. Exacerbation rate declined 42% on top of bronchodilation. One study was 42%, the other one was 24%, but the SGRQ also was improved. The medicine is called Ohtuvayre, approved June 2024. So you add ensifentrine for persistent dyspnea and exacerbations if you're on dual bronchodilators. So it's the first new inhaled mechanism in COPD in 20 years. One drug, phosphodiesterase 3 and 4 inhibition, and it's added on for LAMA-LABA dyspnea. Case number 7 or study number 7 is pulmonary rehab, effects exceeding most drugs on patient-centered outcomes. This is a 200 multi-center patient study, Griffiths et al. And Lancet, basically showed a 49-meter 6-minute walk improvement, or 43-minute 6-minute walk in the Cochrane database, decreased hospitalizations, significantly improved dyspnea, quality of life. And after an acute exacerbation of COPD, the Poohan 2011 trial showed that you would have much less likelihood for readmission. So post-exacerbation pulmonary rehab has a benefit, and the benefits exceed most pharmacologic agents, but it's still only prescribed for less than 10% of eligible patients. It improves exercise capacity, as we show in dyspnea, quality of life, start within 2 weeks of acute exacerbation COPD discharge, as per the Poohan 2011 JAMA article. Paper number 8 is the Antonison, how to diagnose COPD. It's still used in the GOLD 2026 criteria, the most recent guidelines in the reduced trial, all in one. So acute exacerbation COPD, you have dyspnea, sputum volume, and sputum purulence. All three of them, the number needed to treat 3.8 to prevent a failure. That basically is antibiotics. You have to treat if you have a type 1 Antonison criteria, which is 3 out of 3. So that would be a goal, an indication to start antibiotics. How about systemic steroids? 1999 showed Nia Woner basically showed that there was an improvement if you started steroids in patients with exacerbations, but the most quoted study, the reduced 2013 trial, 314 patients, showed that a 5-day prednisone 40 milligrams was just as good as the 14-day course. So the GOLD 2026 recommendations recommend 5 to 7 days. Antibiotics are if you have 2 out of 3 of the Antonison criteria, and including purulence. Type 1 gives you a number needed to treat of 3.8 patients to prevent a failure, and 8 weeks, no added benefit, more harm. So if you treat an 8-week course versus a 2-week course, there was no added benefit, more harm, but also 2 weeks versus 5 days. 5 days is just as good. So then we have a non-invasive ventilator for COPD exacerbation. So we have the Brochard ICU trial, 85 patients at ICU in France, and we have the Plant study, which looked at hospital ward intubation rate was 26% versus 74% in the ICU trial, and 9% versus 29% was the mortality in the in-hospital trial by Plant et al. Basically, Cochrane database 2017 showed that you were able to stave off intubation 60% of the time in hypercapnic acute exacerbation COPD patients. The ICU length of stay was much less, 4 days, and hospital length of stay, 3.4 days. When would you use non-invasive ventilator? When your pH was about 7.25 to 7.35, PCO2 greater than 45, and you didn't have a lot of excess secretions. The no benefit in most severe acidemic patients. Those patients needed ICU level non-invasive ventilation. That was the caveat. And the nocturnal home non-invasive ventilator, Marin 2017 trial showed that non-invasive ventilators decreased readmission, increased 12-month survival. So if you have a patient with COPD who just had been intubated recently and now is home, per the Marin 2017 trial, it showed decreased readmission. So non-invasive ventilator in hypercapnic acute exacerbation COPD decreases the risk of intubation by 60%. Mortality is decreased by half. Use it when your pH is between 7.25 and 7.35, PCO2 greater than 45, and it works in the general ward as well. No improvement at 1 hour, then you have to escalate. And then number 10 is the new Eosinophilic COPD is now a precision medicine target. 2 FDA-approved biologics. We have dupilumab and mepolizumab in 2026. The BOREAS and NOTUS trials are the most commonly quoted trials when it comes to dupilumab, 300 milligrams every 2 weeks, decreased exacerbations by 34%. FEV1 was increased as well by 190 cc's, FDA approved. This is for the chronic bronchitis phenotype. Again, this is for patients who have an eosinophil count greater than 300. The matinee trial was a mepolizumab. The difference, I believe, there was the eosinophil count did not have to be greater than 300. I think it was greater than 150. Decreased exacerbations less than the dupilumab by 21%. And emphysema only included, and so it's a little broader than the chronic bronchitis phenotype of the BOREAS and NOTUS. So 2 FDA-approved biologics for eosinophilic COPD, that would be dupilumab, chronic bronchitis phenotype, and mepolizumab, which includes the emphysema phenotype. And then if you look at the 5 more that you should know about, the FLAME trial, we talked about LAMA LABA beating ICS LABA in the low eosinophil subgroup. Galathea Terranova benralizumab was a negative trial in COPD, so Fasenra did not work. For that, the RETHINK trial, ICS LABA ineffective in PRISM overdiagnosed COPD. ICS LABA in preserved ratio impaired spirometry showed no improvement in symptoms, exacerbations, or FEV1. It confirmed that ICS overtreatment in non-obstructed patients is useless and potentially harmful. Then we have an honorable mention of Liberate NET studies. You definitely have to know the NETT trial for the boards, lung volume reduction surgery, increased survival in upper lobe emphysema, low exercise capacity. They still like to ask that, upper lobe emphysema, low exercise capacity. And then the Liberate trial, which is looking at the endobronchial valves, increased FEV1, and also looking at heterogeneous emphysema without collateral ventilation. And reduced trial, we talked about 5 days versus 14 days, and basically showed it was non-inferior to 14 days for re-exacerbation. And that's confirmed in the GOLD 2026. To summarize, we went over oxygen therapy, not MRC LOTT, went over the lung health study, decreased FEV1. The UPLIFT trial was the foundational Spiriva or Tiotropium. TORCH is ICS LABA for eosinophilic exacerbators. You should never use ICS alone in COPD. IMPACT and ETHOS looked at triple therapy, ENHANCE 1 and 2 for ensifentrine or Ohtuvayre. Griffiths looked at pulmonary rehab, and Tonison is the diagnosis of COPD. Brochard implant non-invasive ventilator. BOREAS NOTUS was the dupilumab, and matinee is the mepolizumab trials. And that's it.